The parietal cells of the stomach secrete hydrochloric acid to maintain a luminal pH of 1.0 to 2.0. This makes the concentration of hydrogen ions inside the stomach over 3 million times greater than that of arterial blood. This high acidity, combined with the proteolytic enzyme pepsin, creates a biological paradox. The gastric juice contains the exact components required to rapidly hydrolyze and dissolve cellular proteins. To prevent autodigestion, the literal dissolving of its own tissues, the stomach employs a multi-layered physical and chemical shield known as the gastric mucosal barrier. Even when minor trauma desquamates a segment of the epithelium, neighboring cells rapidly flatten and migrate across the basement membrane. This process, called restitution, restores epithelial continuity within 30 minutes without requiring cell division. Mastering these defensive layers is a high-yield exam topic and the foundation for treating peptic ulcer disease. We will build this defense system from the ground up, layer by layer, and then demonstrate how modern pharmacology manipulates these pathways. Ultimately, the stomach's survival depends on an active, metabolically expensive cellular effort maintained every minute of the day. The primary defense begins with surface mucus cells, which synthesize a water-insoluble, hydrated gel layer composed of high molecular weight glycoproteins called mucins. Students often mistake this for a simple physical wall. However, the mucin gel alone is permeable to protons and cannot stop acid on its own. The actual mechanism is an active chemical neutralization. As seen here, epithelial cells secrete bicarbonate ions directly into the unstirred mucin matrix. This creates a steep pH gradient. While the lumen remains highly acidic, the microenvironment immediately adjacent to the cell membranes is maintained at a near-neutral pH of approximately 7.0. As hydrogen ions diffuse from the lumen into the gel, they encounter the trapped bicarbonate and are neutralized before they can reach the epithelial surface. This gradient also protects against pepsin. The enzyme is inactivated at a pH greater than 5.0 and irreversibly denatured at a pH of 7.0, preventing it from digesting apical membrane proteins. This first line of defense is an active chemical neutralization zone created by the synergy of the mucus matrix and bicarbonate secretion. If a surge of protons manages to breach the chemical gel, they encounter the physical barrier of the epithelial sheet. The apical membranes of these cells are rich in hydrophobic phospholipids and cholesterol. This lipid composition makes the membrane virtually impermeable to the passive diffusion of polar hydrogen ions. Furthermore, high-resistance tight junctions, called zonula occludens, fuse the lateral membranes of adjacent cells together. This seals the paralegal spaces and prevents the back leak of protons into the lamina propria. Beneath the epithelium, a rich capillary network within the lamina propria serves as an essential secondary defense. During active acid secretion, the parietal cell extrudes vast quantities of bicarbonate into the capillary blood. This phenomenon, known as the alkaline tide, provides a continuous supply of buffer to the superficial mucus cells. This blood flow delivers the necessary bicarbonate to refuel the chemical shield and rapidly washes away any hydrogen ions that manage to leak across the epithelium. In this system, the very act of producing hydrochloric acid generates the bicarbonate needed to protect the mucosa from it. The continuous local synthesis of prostaglandins, specifically prostaglandin E2 and prostacyclin, regulates these defensive mechanisms. These lipid mediators are synthesized on demand from arachidonic acid by the constituent enzyme cyclooxygenase 1, or COX-1. Prostaglandins bang to EP3 receptors on mucus cells to stimulate mucus and bicarbonate secretion, while promoting the local vasodilation required for high mucosal blood flow. Simultaneously, they bind to GI-coupled EP3 receptors on parietal cells to suppress intracellular cyclic AMP, which directly reduces acid production. This regulatory balance is disrupted when a patient takes non-steroidal anti-inflammatory drugs, or NSAIDs, for chronic pain. NSAIDs non-selectively block the COX-1 enzyme, which halts the production of protective prostaglandins. Without these mediators, acid secretion increases while mucus secretion, bicarbonate production, and mucosal blood flow simultaneously fail. This internal collapse leads to the classic presentation of peptic ulcers, epigastric burning pain, vomiting blood, or melena, dark, tarry stools indicating upper gastrointestinal bleeding. NSAIDs cause ulceration by biochemically disarming the stomach's natural defenses from the inside out. To treat these ulcers, pharmacotherapy must suppress hydrochloric acid secretion by blocking specific molecular targets on the parietal cell. The parietal cell is stimulated by three pathways: histamine binding to H2 receptors, acetylcholine binding to M3 receptors, and gastrin binding to CCK2 receptors. These receptors activate intracellular secondary messengers, specifically cyclic AMP and calcium, to drive acid production. All of these pathways converge on a single exit point, the apical hydrogen-potassium ATPase, commonly known as the proton pump. H2 receptor antagonists, such as famotidine, competitively block the histamine pathway. This prevents the rise of intracellular cyclic AMP. However, because the vagal and gastrin pathways remain active, H2 blockers only provide partial suppression of total acid output. Proton pump inhibitors, such as Omeprazole, are more effective at suppressing acid. These drugs bypass the receptors and bind covalently to the proton pump itself. By inactivating the final common pathway, they block proton extrusion regardless of how the cell is stimulated. Because this bond is irreversible, the pump is permanently paralyzed, making PPIs the most efficacious agents for acid suppression. Understanding this cellular convergence explains why targeting the final transport pump is more effective than blocking individual upstream receptors. Before we conclude, let's apply these concepts to high-yield exam questions. Remember that the true barrier is the synergy between mucin and bicarbonate, which establishes a pH gradient to denature pepsin. Prostaglandins regulate this entire system, and PPIs provide the most effective therapy by locking the final common pathway of acid extrusion. Let's use the active recall engine to test your understanding of these specific academic principles. Question 1 asks which component is directly responsible for inactivating pepsin. The correct answer is C. The explanation notes that while pepsin is active in acidic environments, bicarbonate raises the local pH to 7.0. This gradient denatures the enzyme before it reaches the cells. Question 3 asks why PPIs are more effective than H2 receptor antagonists. The answer is A. As the explanation states, stimulants like histamine, acetylcholine, and gastrin all converge on the proton pump. Blocking this final common transport pathway renders all upstream signals ineffective. Deeply understanding these first principles of physiology is the standard for mastering clinical pharmacology and providing effective patient care.